طلعتكم؟
نعم دكتور، واضحة.
تمام. رح نبدي اليوم إن شاء الله نكمل محاضرات ال third lecture of our cardiology congenital heart disease in pediatric. We will continue before the midterm. We talk about the general investigation, introduction to cardiology, and the second lecture talking about the most common congenital heart disease, including the VSD. Today we will talk about the ASD, atrial septal defect, and the PDA, patent ductus arteriosus. These two congenital heart disease included in the cyanotic congenital heart disease, as we said earlier. This is the most common congenital heart disease than the cyanotic congenital heart disease. So let's start with the atrial septal defect, which can occur in any portion in the atrial septum, and these including three types. The first type will be the secondum, ASD, and this is the most common type of atrial septal defect, constituting about 70 to 80% of atrial septal defect, while the second type will be the primum ASD, constituting about 20 to 25% of the types of atrial septal defect, and the third type is which is rare, called sinus venosus ASD. Less commonly, there is a total absence of the interatrial septum, so this will constitute and creating a single atrium. There is no left atrium or right atrium. There will be just a single big atrium for the infant or neonate. Isolated secondum ASD account for about 7% of the congenital heart disease. Remember the VSD, we talked about it, the percentage of it was 30%. This is of congenital heart disease. The ASD constitutes about 7% of congenital heart disease. The majority of cases of ASD are sporadic. There is autosomal dominance inheritance occur as a part of a syndrome called Holt-Oram syndrome. This is an example. There is many diseases associated with congenital heart disease. An example of it, we call it Holt-Oram syndrome. This constitutes of hypoplastic or absent radius with first degree heart block and with atrial septal defect. Patent foramen ovale, we hear such a term or word in the echo reports. It does not require usually a surgical treatment. It is a common echo finding during infancy, and it is usually of no hemodynamic significance, and it is not considered atrial septal defect. Patent foramen ovale may present in about 15 to 30% of adult population. لذلك الأهل دائما يجونا مرات دكتور عنده فتحة، فهو نطمنهم البيتنت foramen ovale present أو موجود بتقريبا ربع البوبوليشن، يعني 25% of the adult population ممكن يكون عندهم patent from an ovary, and it is usually not require any surgical treatment. ممكن مرات يصير عندهم complication، ممكن يصير عندهم shunt. This constitute an indication for closure, but usually we left it without any treatment if the patient didn't have any complication. This picture on the left side, you will see the A and B. The A constitutes the Ethereal Septal Defect secundum, ASD secundum, while the B, the figure B, constitutes the ASD primum. This is the primum. We see it in the lower part near the valve, mitral and tricuspid valve, while the secundum usually in the middle. Small or short notes about the Ethereal Septal Defect secundum type, which is we say which is the most common form of ASD and usually associated with structurally normal atrioventricular valve. ونحن قلنا here in the middle. Usually the mitral with tricuspid valve usually are normal. May be associated with atrioventricular valve disease like mitral valve prolapse has been described and associated with this defect, but is rarely of important clinical consideration. لذلك احنا مرات بنشوف mitral valve prolapse بالايكو we look for interstitial secundum or ASD secundum because there is an association between the two. ASD secundum may be single or multiple. إن مرات تقروها يسموها بالإيكو fenestrated intra-arterial septum، يعني بالعربي ترجمها نقول مشرشبة، فهي ممكن إنه تكون عدة فتحات ضمن السبتم، مو بس فتحة واحدة، تسمى fenestrated intra-arterial septum. طبعا ASD secundum usually it's common in females. Incidence معناتها 3 to 1 female to male, and usually we see it in very common in female patient and especially in older age group. Usually if it is small size they do not produce the symptoms before the second decade of life. لذلك نشوفوا مرات تلاقي عمرها 30 40 سنة يجونا عندها مسوية echo for any reason, for palpitation or anyhow this exemption or dyspnea, and we found the patient had ASD secundum. The opening more than 2 cm in diameter are common in symptomatic older children. Another association with the ASD secundum is partial anomalous pulmonary venous return, usually of right upper pulmonary vein. This finding usually we find it by echo. If it is difficult or if we do angio on the cath lab, we enter into the, we check the pulmonary veins and we see if there is any anomaly in one of them associated with ASD. What are the degree of left-right shunting depending on what? Usually first on the size of the defect and the relative compliance of the right and left ventricle, and third the relative vascular resistance in the pulmonary and systemic circulation. So the symptoms in infant with ASD is related to the structure of the right ventricle in early life, usually when its muscular wall is thick and less compliant, this limiting the left to right shunt. As the infant become older and a dropping of the pulmonary vascular resistance, usually the right ventricular wall become thinner and the left to right shunt across the ASD will increase. This blood flow through the right side of the heart result in enlargement of the right atrium and ventricle and dilatation of the pulmonary artery. لذلك احنا when you look for when examine the patient in the echo, when we see dilatation of the right side of the heart, right atrium and right ventricle going to the pulmonary artery, usually we suspect arterial septal defect, so we should clearly examine the arterial septum looking for any defect, ASD defect. Then the left atrium may also enlarge greatly but the left ventricle and the aorta will be normal in size. What are the clinical manifestations of the patient with ASD? Usually, children with ASD secondary is most often asymptomatic. قلنا لكم احنا usually ذولا most common تكون small in size, or small in size does not produce complication until after the second decade of life. لذلك most of children they are usually asymptomatic. The complication of it, like arrhythmia, RV failure, all these complications occur after the 20s, يجونا بال30s, يجونا أمامهم 40 years, with dyspnea, with exertion, with palpitation, with arrhythmia, and we did echo for them, and as I said, it is usual. They are usually females, and we found they have arterial septal defect. Even extremely large secondary ASD rarely produce clinically heart failure in the childhood. In younger children, mild failure to 5 may be present if the ASD is large enough to produce failure to 5. In older children, varying degree of exercise intolerance may be noted if the ASD is very large enough to produce symptoms. Examination of the chest, what we will find in the patient with ASD may include mild left precordial bulge, right ventricular systolic lift is generally palpable, loud first heart sound, and the second heart sound is characteristically widely splitting and fixed. This is characteristic for the ASD. When you find a fixed splitting second heart sound, this is characteristic for arterial septal defect. While normally the splitting, as we know, the difference between respiration and expiration, the A2 and P2, the splitting between them is different according to the respiratory cycle. When we found a fixed splitting and wide fixed splitting of the second heart sound, this means we have an arterial septal defect. The fourth part in the auscultation, usually the duration of the right ventricular ejection varies with respiration. With inspiration, increase the right ventricular volume and delaying the closure of the pulmonary valve. This is the delay valve closure will cause the fixed splitting. same of uh, number 3. Fifth, systolic ejection murmur is heard in patients with ASD syndrome and rarely accompanied by frill. This is best heard at the left, middle, and upper sternal border. The cause of this systolic ejection murmur is produced by increased flow across the right ventricular outflow tract into the pulmonary artery, not by low pressure flow across the ASD. ذلك هاي الطلاب دائما يخطرون بيها نقول له شنو المرمر اللي نسمعها بالاي اس دي هسه نقول systolic ejection murmur due to blood flow through the ASD وهو هذا الخطأ الشائع. احنا ما عندنا هنا ال pressure between the two atrium is very low, لذلك cannot produce a murmur. The murmur of ASD is due to overflow that pass through the pulmonary or right ventricular outflow and through the pulmonary valve. لذلك this will produce a systolic ejection murmur, not because of the shunt through the ASD, like the VSD. 6 is a short rumbling mid-diastolic murmur produced by increased volume of blood flow across the tricuspid valve. Is often audible at the lower left sternal border. 7. This finding, which may be mild and is heard best with the bell of a stethoscope, usually indicate QPQS ratio of at least 2 to 1. ECG will show volume overload مثل ما قلنا احنا of the right ventricle. احنا قلنا right ventricular dilatation and overload of the right side, and the QRS axis may be normal or exhibit the right axis deviation. Minor right ventricular conduction delay RSR pattern and the right epicardial lead may be present. The treatment is usually surgical or by catheter. In the previous days, before 10 years or 20 years, all the patients with ASD usually closed by surgery or mid-sternotomy. Nowadays, most of the ASD usually we closed by us, by in the cath lab, by easy procedure. Can the day procedure when patient discharge in the second day, we close it through the cath. We enter through the femoral artery and femoral vein and go to the IVC vein to the right atrium, going to the passing through the left atrium, and we put an occluder like this occluder. We see it in the bottom of the page. This occluder is a stainless steel and it has the ability to go inside the cath, and when we open it, we take this shape. It has the ability to turn to taking this shape, which we see this shape in circular manner. So open and will close the interarterial septum, and we will be completely fibrosed and with the septum within 4 to 6 months. So we close it for, usually we wait after 4 years of age. If the septum does not close spontaneously, usually we arrange for appointment for cath and we close it by this occluder. Usually, transcatheter closure is advised for all symptomatic patients, or also for asymptomatic patients with a QPQS ratio of at least 2 to 1. The timing of elective closure is usually after the first year and before entry in the school, and usually after, as we said, after 4 years of age. If it doesn't close spontaneously, usually we close it by the calf. This is all about the ASD, and the second part of our lecture today will talk about the patent ductus arteriosus, and usually the aortic end of the ductus is just distal to the origin of the left subclavian artery, and the ductus enters the pulmonary artery, usually at its bifurcation. This type of congenital heart disease is also common in females more than the males, usually 2 to 1 in female to male ratio, and may be associated with torch infection like maternal rubella during early pregnancy. So, torch infection associated with congenital heart disease, as we know, one of them is patent ductus arteriosus, and it is one of the common problems in the premature neonates. Most of the premature neonates, we see them, they refer them to us, and we see they complain for persistence of patent ductus arteriosus, not closed, or may be found in term infant, and this full-term unit, the wall of the ductus is deficient in both the mucoid endothelial layer and the muscular media. Well, this is the cause of PDA in full term, while in premature, the PDA usually have normal structure, have no deficiency, and the cause of persistence of patency is because of hypoxia and immaturity of the unit. So, because of this difference in the structure of the PDA persisting beyond the first few weeks of life in the term infant usually rarely will close continuously. So we need pharmacological or surgical intervention, whereas early pharmacological or surgical intervention is not required in premature infant because spontaneous closure occur in most of the instances. الدايجرام دي شوفنا ال PDA، بنشوف احنا هذا البلمونري بالبلو بارت، وبينما هذا الريد اللي هو الايورتيك ارش، هذا الدكت اللي هو between the pulmonary and the aortic part هو البيتنت ductus arteriosus. لذلك احنا بنصعد when we want to close it by car، راح ندخل من ال IVC من الفيمورال بين ال IVC لرايت اتريوم لرايت ventricle، وبعدين نوصل للبلمونري artery. من البلمونري هنا بالبايفوركيشن، ونظل نحاول انه طبعا براديوجرافيكلي احنا ما راح نشوف الاوبننج هيك ملونه، راح نظل بلايندلي نحاول ندخل الكابيتر هاي المنطقه لحد ما يعبر، من يعبر رأسا بالارش راح ينزل بالديسندنج ايورتا، معناها احنا عبرنا من البلمونري للايورتيك ارش، ومن خلالها راح نصعد الكابيتال، راح نصعد الابلودر، هي ابلودر مشابهه لهاي اللي شفناها مال اي اس دي، هسه نشوف صورها، ونخلي الابلودر هنا بالمنتصف مال this duct and will be closed. Previously also this procedure did by midsternatomy. Now is one of the simplest procedure. Usually the first procedure, the intern will learn it to close. The defect will be the PDA, because one of the simplest procedure in the cath lab in the congenital heart disease.
زين دكتور، الدخول ليش ما يكون عن طريق الارتري، عن طريق الارش وبعدين للpulmonary vein؟
ممكن انه ندخل من الجهة الثانية، من الجهتين ندخل، بس هناك يكون اصعب. زين انت هنا واضح طريقك من البايفوركيشن، بينما هناك وين راح تلقاه بالارش وبالدور فيه. مرات اذا كلش سمول وما نقدر نفوت، ممكن ندخل من الطريقة الثانية، وايضا نسوي فدلوب عن طريقهم بالجهتين، وندخل الاوكلودر ونسدها. بس هي يوجوالي الاوكلودر اتجاهها للسدة هو عن طريق الايورتا، فلذلك الدخلة مالتنا تكون من البلمونري تكون اسهل، هي وجهها يكون عن طريق الايورتيك بارت. زين هسه نشوف الشكل مالتها من تسوي لنا كلوجر. فحتى اذا دخلنا من الايورتيك هم راح نسوي سنيه ونرجع الكافيتر نفوت من البلمونري الايورتيك. الوجه مالته لازم يكون باتجاه الايورتيك وول. واضح؟
تمام دكتور.
ماكو شيء يعني فيكست وثابت بالكونجنتال. ممكن ندخل من هنا، ندخل من الجهه الثانيه حسب البروسيجر وحسب التايبس. بيها ماني تايبس، هي 5 تايبس او بي دي اي. ما ندخل بالديتيلز مالتها. اكو الويندو تايب، واكو المخروطيه، واكو السيركولار، فديفرنت تايبس. بس احنا حسب البروسيجر تخطط الشيء، وبعدين من يطلع لانذر تايب او ممكن سمول، احنا نظل نحاول قدر الامكان ما يجي من البرفوركيشن، نرجع من الايورتيك اند ممكن ندخل عليها. وقلت لك نسوي سنير ولوب وكلوز ات فروم ذا ايورتيك بارت مثل ما قلت. كل شيء ممكن متوقع بالكونجنتال هارت ديزيز. بروسيجر عادة تطول عندنا، يعني احنا سادين خلال 10 دقائق، ممكن انه في دي نطول بيها ساعتين او ثلاثة، تطلع فيري سمول او ما نقدر نوصل، او different type، او there is another congenital anomaly with it. وتخربط الامور كلها، وتشوف الانترنس مالتنا كله يتغير بالبروسيجر. PDA is usually seen in 10% of patients with other congenital heart lesion, and usually often plays a critical role in providing pulmonary blood flow when the right ventricular outflow tract is stenotic or atretic. This will provide systemic blood flow in presence of aortic coarctation or interruption. لذلك اكو specific type of disease اما نسموهم PDA dependent lesion. يعني life of this patient will depend on the persistence of PDA. مثل ليش؟ مثل الانتربتد aortic arch. هذا الايورتيك arch نشوفه فوق البي دي اي closed. هذا اللايف مالته البيشنت تعتمد على البي دي اي. بما البي دي اي closed ما راح يوصل circulation للارش، وما راح يوصل systemic circulation للبدن. The patient will die. What are the shunt depend on what? On the PDA. Like the VSD, this will depend on the size of the ductus, the ratio of pulmonary to systemic vascular resistance. كل ما أعلى السيستميك راح يكون للpulmonary، وإذا الpulmonary أعلى راح يكون الفلو from the pulmonary to the systemic. So the PDA is a small pressure within the pulmonary artery, the right ventricle, and the right atrium will be normal, while if the PDA is large, this will cause elevation of the pulmonary artery pressure and will cause pulmonary hypertension and will end with Eisenmenger syndrome if not treated. So, patients with large PDA are extremely high risk for development of pulmonary vascular disease and pulmonary hypertension if left unoperated. Pulmonary pressure is wide because of runoff of blood into pulmonary artery during the diastole. What are the clinical findings in patients with PDA? Usually asymptomatic in most of cases detected by clinical examination. If it is a small duct, usually the patient is asymptomatic, just we found an incidental murmur, they sent him for a murmur, and we see the patient with persistent ductus arteriosus. شايفين أعمار 30 40 سنة females يجونا and for incidental finding they send her for echo, for cesarean or preoperative evaluation, and we found an incidental patent ductus arteriosus, and we usually close it by cath. While the large duct usually may cause retardation of physical growth, maybe major manifestation in infants with large shunt, and may result in heart failure, similar to that encountered in infants with large VSD. Also, wide pulse pressure may found in these patients. The heart usually is normal in size when the duct is small, but moderately or grossly enlarged in cases with large PDA, and the apical impulse is prominent with cardiac enlargement, having a full maximum in the second left intercostal space. لذلك احنا عادة by palpation بالpulmonary area راح نلقى فرغ and when we auscultate the heart usually we found the classical continuous murmur have the characteristic at your grade for PDA. There is many disease can cause machinery murmur, fistulas, but for your grade, this is the classical. For you, machinery murmur meaning a PDA. So when we hear on the second intercostal space, the left systolic and diastolic murmur, this means you have a PDA. The patient may have a PDA. Usually radiate down the left sternal border or may to the left clavicle, and you also may radiate to the back. When pulmonary vascular resistance increases, the diastolic component of the murmur may be less prominent or absent, and this may cause the loud of second heart sound. We call it the loud P2. This indicates the patient starting to develop pulmonary hypertension. Left to right shunt, mitral diastolic murmur may be also audible at the apex as a result of increased volume of blood flow across the mitral valve. What are the diagnostic procedure we can done for this patient? Usually, if the ductus is small, the patient is asymptomatic, and the echo of cardiac chamber will be normal, just a small PDA. We see it by echo, and usually it is very obvious by echocardiography. And all of the investigation, the chest X-ray will be normal, the ECG will be normal. Just we found by auscultation machinery murmur, and do echo we found a small PDA. Well, the patient with large PDA show prominence of pulmonary artery and increase pulmonary vascular marking. So about the radiological finding will include the cardiac size depending on the degree of left-right shunting. It may be small, normal if the PDA is small, or moderately to markedly enlarged if the PDA is large. Also, if the PDA is large, the chambers involved are also large, like the left atrium and the left ventricle, and the aortic knob is also will be prominent. Also, the same finding will be in the echo. The cardiac chamber we say area will be normal if the PDA is small, while the large duct, the left ventricle, and will be enlarged, and then will end with biventricular hypertrophy. What are the complications of PDA prognosis? Patient with small PDA may live a normal lifespan with few or no cardiac symptoms, but late manifestation may occur. Spontaneous closure of the ductus after infancy is extremely rare. لذلك احنا عادة we close it in the after 6 months of age to 9 months of age, according to the patient's symptoms. If it is asymptomatic, usually before 1 year of age, usually we close it. Waiting in the first 6 months to be closed spontaneously. If the PDA closed spontaneously, we no need for the operation, so we defer the operation until the end of the first year of life. This is for the asymptomatic patient and not affecting the patient life, symptoms, or the heart. If it is asymptomatic, usually we try to close it as early as possible as we can. Cardiac failure or heart failure usually occurs in early infancy in the presence of large ductus, as we say. Patients are liable for infective endocarditis. Pulmonary or systemic embolization may occur at any time, and rare complication may include aneurysmal dilatation of pulmonary artery or the duct, calcification of the duct, or patient if they have large PDA may found pulmonary hypertension or Eisenmenger syndrome. Many patients usually because of poor screening and poor follow-up in our system, usually we just found the best presentation of them will be pulmonary hypertension or Eisenmenger syndrome, and when we look for the cause, we found the patient had a missed large PDA and causing Eisenmenger syndrome for him without knowing the cause previously. Then what are the treatment of PDA? As we say, irrespective of the age, patient with PDA should be closed early or late. We should not leave the patient with PDA because of all the previous mentioned complications. So should be closed by surgical or transcatheter closure. In patient with small PDA, the rationale for closure is the prevention of bacterial endocarditis or other late complication we mentioned earlier. In patients with moderate or large PDA, closure is done to treat the heart failure or prevention of development of pulmonary vascular disease and subsequent Eisenmenger syndrome, or both of them. Usually, there is a trials of giving indomethacin or Indoseed or porphine may be given to enhance the closure of the duct in the first 2 weeks of life, while this trial is of no benefit after this age. Usually, successful trial of closure to be happen in the first 10 days to 2 weeks of life. If it do not close, we wait until the patient will become slightly older, and we close it by transcatheter closure. موضوعين قصيرة اللي هي البلمونري ستينوسيس and aortic stenosis. ما راح ندخل بالديتيلز مالتها، هي موجودة بالكتاب مالتكم. and usually التريتمنت مالتهم ما عادة if it is asymptomatic usually we do just a follow-up, while symptomatic patient we do a balloon dilatation for them, also by lab for aortic stenosis, which produce usually ejection systolic murmur in the right upper sternal border, while the pulmonary stenosis usually producing pulmonary stenosis in the left upper sternal border. راح ندخل through the pulmonary valve and or the aortic valve, and would do dilatation for children with aortic and pulmonary stenosis. Even in adult with pulmonary stenosis, the same treatment, while with adult patient with aortic stenosis, the management will be different. This will maybe associated with calcification. So the balloon is contraindicated, may distract the valve or cause the destruction of this calcification and showering of emboli and causing disastrous CVA stroke for the patient. So the treatment here will be surgical. Lastly, this is the picture of the closure of the ductus. مثل ما يسألونا الولد احنا هنا نشوفها بالاي او الكافيتر مالتنا، هاي lateral view مو بالانتيريور بارت، نشوفها بالبلمونري ومتصل بالديسيندنج ايورتا، نشوفها بالمين pulmonary artery، وهاي الدكتس اللي هي تربط بين المين pulmonary artery اللي احنا نفوت بخلالها بالكافيتر، وبعدين نصعد الأبلودة، والأبلودة وراها من نفتحها هي راح تاخذ الشيب مالتها اللي هو الشيب راح يكون على الايورتيك بارت، راح يسوي لنا closure all of the duct، while the other end مالتها راح تكون inside the pulmonary artery, and this will be completely fibrosed within 4 to 6 months. نقول للمريض حركات قوية ماكو حتى ما يصير لحد ما يصير complete fibrosis of the duct within the wall, and after this will be the patient completely like the normal patient. بالsecond picture بنشوفها the right side، ما عندنا فقط الايورتيك هذا من اللون، بعد مدى يعبر على البلمونري، وهي بالبداية من لوننا شوفوا شلون الداي جاي تعبر من الايورتيك للبلمونري، انه معناتها اكو patent ductus arteriosus. بالتلوين الثاني حطينا الأكلودة التلوين فقط للارش، ما جاي يعبر للبلمونري. طبعا هاي احنا نلون قبل ما نحط الأكلودة، ونلون مرة ثانية قبل ما نسوي لها ريليز، نشوف إذا أكو جاي تعبر أو لا. إذا تعبر مرات نسحبها الأكلودة ونحط لنا واحدة ثانية أو حجم سايز أكبر لحد إنه نتأكد إنه ما جاي يعبر من الأيورتيك للبلمونري، معناتها الفيت its size and its position. بعدين نسوي لها release from his position، راح تاخذ الرايت position مالتها ونسحب الكافيتر، والpatient can be discharged after a few hours. Usually احنا discharge the second day, but even sometimes even at night after 3-4 hours if no complication can discharge home safely. This is the last slide ما أعتقد بعد عندنا شيء ثاني. إذا أكو any question. إذا ماكو أي سؤال تقدرون تاخذون راحتكم. نلتقي إن شاء الله الأسبوع القادم.
شكرا دكتور.
الله معكم.